All right, great. Thank you so much for the introduction. Let me share my slides. Hope that this works. All right, can you see my slides? Hearing no, I'm assuming that means yes. Well, so thank you for the invitation to present. MPRINT is new to me, and I'm hoping that I found the right tone about what I'm going to present. Tone in terms of this is interesting to the audience, and hopefully also some new information. As Lang mentioned, I'm a pharmacoepidemiologist by training. I have spent a good amount of time looking at child and maternal health related issues, but not only. My focus is actually across the entire medication safety spectrum. And as we know, this is where observational research really comes in quite a bit because the clinical trial information is commonly limited in this regard. Here are my disclosures. None of them really relates to what I'm describing and presenting today. So what I would like to do is I would like to give you a brief introduction to causal inference studies in real-world data. Some people might say that doesn't exist, but the reality is if we conduct observational studies on medication safety or effectiveness, at the end of the day, we want to make a causal inference. If we want to act upon it, that means that we believe it's true. And so I think it makes sense to have that mindset to think about whether we can make causal inferences or not. I give you a review of real-world data measurement issues related to studies in pregnancy that we have discovered, and a little bit of an idea how to deal with it. Apply this to one example where we looked at a specific teratogenicity issue, and then also give you some outlook on an ongoing study that is funded by NICHD right now that I have in collaboration with Judy Mauro from Harvard, where we are actually trying to use not formal pharmacoepidemiological methods only, but also data mining techniques to accelerate some of that evidence generation that we all are interested in. So first of all, a little bit my thoughts on causal inference. Causal inference mathematically means that I'm distinguishing actually seeing from doing, right? So seeing is the probability of seeing something that this is actually caused by, that this is actually associated with a particular event and an example or a particular exposure. And an example is if Google finds out that people who like fancy coffee also like puppies, then they can, in their advertisement placement, connect those two, and that makes total sense. But that wouldn't mean that Starbucks would invest in doing something, meaning buying people puppies so that they drink more Starbucks coffee, right? So there may be an association, but it's not a causal association. That's the major difference if we're thinking about data, real-world data, that we have the probability for an outcome to happen given that we do something. It's the intervention that matters. And that doing is, of course, something that we can perfectly control in a clinical trial, but we cannot in an observational setting. So causal reasoning really distinguishes seeing from doing. And I think that's extremely important when we think about real-world data, because what we had when we start out is we only have seeing. And it's really the design portion that we overlay to this data that tries to emulate the idea of that we're actually doing something, that we are imposing an intervention on something. There are instances where that works quite well. So this is a study that was conducted by a colleague at FDA, David Graham, that looked at the safety of rosiglitazone versus pioglitazone, two antidiabetic medications. And this is table 1 before there was any adjustment with propensity scores or what have you. And if you compare table 1, those two user groups, they look like randomized, even though they were not. So this is an example where I have a medication that comes on the market together with a sister medication, same indication, same time on the market, same place in diabetes management, and it's almost like a random utilization of those two medications. This is fantastic, right? So I think nobody would doubt that, this is a scenario where I can actually make a causal inference. So randomization, even though it wasn't possible, we have exchangeability, we have positivity, all these things that we usually think about, and accounting for, and we don't have to worry about accounting for attrition, most likely. And then the other most important part, another important part is we don't have a confounding issue, but we also don't really have a measurement problem, because this study focused on myocardial infarction, and we would imagine, and stroke, and we would imagine that major cardiovascular events happen, and I seek healthcare for this, so I don't have to worry that I have certain measurement biases. But in most instances, we don't have that scenario. In real-world data analytics, if I just mine this data, I can show that patients who take antidepressants have more depression. That's just a matter of the indication. Patients who take newer anticoagulants have less cardiovascular events compared to those who take warfarin, and that is usually what we refer to as a healthy user effect or a more affluent user effect. So these are typically patients who can afford the higher copays for brand medications. And so we see healthier patients on the newer medications. Patients who stop statins die sooner. That's an interesting one. That's reverse causality. So, commonly we will stop preventive therapy among patients who are at the end of their lives. So we actually have the statin stopping is actually an indicator for imminent death. Patients on newly approved contraceptives are at higher risk for venous thromboembolism than patients who use an older contraceptive. That is something that is referred to as this depletion of susceptibles, a very common mistake that people make in pharmacoepi if they don't think about new user designs. Patients who take beta blockers for at least 3 months after myocardial infarction have better survival than patients who don't. That's immortal time bias. If I take drug for 3 months, that means that I'm immortal during that time period. So that's kind of an investigator-induced bias that can be created. And patients who take anti-diabetics have more depression. That is related to the fact that patients who take antidiabetics are regularly evaluated, which means that the chance for detecting depression is simply higher because they have more common interactions with the healthcare system. None of this is causal, even though all of this sounds intuitively just right. And it's important to think about what is in the data. And these are all these associations. This is the seeing, that is not the doing, that we first need to address, because before we really can look at specific causal relationships. So isolating the effect of an exposure on an outcome in real-world data really requires a deep understanding of the process that generated the data. So what is in the data before we keep going. And that is really related to observational data, so assessments of claims data or EHR data as much as registries. Because in registries, we typically have just an exposed group, and the unexposed group is still a reference group that lives in real-world life in many instances. So we still lack randomization, and we still have issues related to this. So we have the confounding part that is extremely important, but we also have measurement issues, which registries, of course, try to address, pregnancy registries, by having very protocol-based assessments. But as I said, this is usually in one arm, but not in the comparator arm. So now let's go towards pregnancy-related work. And one important part that I wanted to spend a little bit more time today about is to think about timing of exposure in pregnancy. Most of the people in the room probably know how important that is when we're looking at embryogenesis and what each week of gestation really means in terms of teratogenicity, but also in terms of anything else that happens in development of the fetus and progress of pregnancy. So the effects are common, drug and medication effects are commonly dependent on prenatal exposure timing. We know that. And exact timing of pregnancy onset really only exists in vitro fertilization scenarios. In most other instances, we really don't know exactly when conception happened, not in EHR data and not in claims data for sure. And this is complicated with real-world data even more because some pregnancies do not result in any clinical care and are obscured. And that might actually be something that even becomes more increasingly a research issue in this country with, the increasing abortion restrictions that we don't really see all pregnancies. That's a problem from a research perspective. And then detail on gestational age is incomplete, especially for abortions. Many abortions happen before prenatal care started, which means, again, we don't know exactly when conception happened. And this has implications for causal inference work. And then coding and documentation, especially in claims data, is incomplete. So let's just think this through. This is really a measurement dilemma. So if we have conception, we have a medication exposure that reaches into the first trimester, If I underestimate the gestational age, and I'm assuming that conception actually occurred later, then I will not capture that this pregnancy actually had a specific medication exposure that I'm interested in. And that would overestimate the background risk because the actual drug effect is now attributed to my control group, and that would create a bias towards the null. Likewise, if I estimate gestational age as too long, and I actually have a scenario where drug exposure was discontinued before conception, but I'm assuming that this was actually a drug exposure during conception, I will underestimate the actual drug risk, which in reality didn't really happen. And again, I bias towards the null. So in both of these instances, I'm actually I'm facing a dilemma if in not timing pregnancy and conception right, that will not allow me to identify a safety event that might really matter because I'm biased towards not finding it. So if you're now thinking about how do we really identify a pregnancy period, there's a lot of different pieces of terminology and claims data that comes to mind. We have pregnancy endpoints, normal delivery, mother with single life born, and so on. We have gestational age codes that are used in ICD-10 terminology more so than what was available in ICD-9. And then we have a bunch of pregnancy markers, prenatal screening, exams, and things of that nature that also give us the idea about the care that was experienced during pregnancy, but also it allows us more accuracy in timing pregnancy onset. So the way that is actually typically then established, and there are several pregnancy algorithms that are now available that have been validated against all kinds of different things. So you may have, the entire obstetric history of a woman. Like here we have pregnancy visits, we have a miscarriage event, there's an ultrasound, gestational diabetes test, live birth, and so on. And so typically these pregnancy algorithms start with the endpoint because that's the one that's measured and timed. And they're usually done in a hierarchy based on the endpoints that have better validity than the others. So in this case, this would be live birth. So we identify a live birth event, we estimate gestational age backwards, and that gives us the onset of conception. And then typically all the other events that happen in between that pregnancy episode that we have now locked in as a live birth are removed. So in this case, miscarriage would be removed. This could have been a coding error where there was a concern about miscarriage, but it actually didn't happen, or this is actually referring to a history of a miscarriage that might have been experienced before this particular pregnancy event. And then we basically move on to the next pregnancy event and so on. So the first part is just making sense out of these millions, literally, of encounter codes that are available in a data set and to log in pregnancy episodes. Then, as I mentioned, the gestational age estimation is massively important. And here's one example where we actually compared this. So we estimated gestational age for all pregnancies based on the various pregnancy outcomes, plotted this over time. And then we looked at the timing of the first trimester ultrasound relative to what we had decided was conception based on our coding algorithm. And what you see is that for all these pregnancy endpoints, that seems to be fairly consistent, except for stillbirth. And stillbirth is particularly problematic. And the reason for that is because stillbirth, the gestational age of stillbirth is actually bimodal. So we see that there is a peak of early stillbirth, and then there is a trough, and then there is a later peak of later stillbirth, which actually don't share the same etiology in many instances. So different types of stillbirth for different types of reasons. This here is data that we linked to Florida fetal death records, where we actually have the actual clinical estimate of gestational age among the Medicaid-based stillbirths that we had identified here based on claims data. So for those stillbirths where we don't have ICD codes assigned that give us a GA age, or the prenatal care may have been incomplete and we cannot really estimate very well when actual conception happens, the median GA is assigned, and the median GA is right in the trough where actually the gestational age is the least likely to happen, as you can tell. And that creates this problem in estimating stillbirth rate. So we have actually spent a good amount of time improving our estimation here. We have actually used here machine learning models that use a plethora of information including risk factors for these different types of stillbirth to predict what the best gestational age is. So the major message that I'm trying to present here is this, that the validity of pregnancy algorithms depends on a lot of different pieces that need to be in place. The validity of the algorithms to measure the endpoints. So a stillbirth is not a miscarriage, and we did a lot of chart-based validation to get at a coding algorithm that carves out stillbirths and that are not miscarriages. The completeness of encounter capture, so to make sure that we have the entire pregnancy history, because that allows us a better capture of relevant coding, and then the validity of the gestational age estimates that are obviously created. You see here all papers that we actually published just on establishing these pregnancy episodes and getting the timing right, and there's more in the whole administrative claims data pregnancy community that has been done in this area. But this is a really important message, that if I don't get my pregnancy episodes right, a lot of other things don't work. So I want to show you how that looks like in an application of one study that we did for the FDA a few years back. This was focused on the risk for fetal or neonatal death or neonatal intensive care unit admission associated with gadolinium exposure that is used for MRI procedures. And the focus that the FDA here really wanted was a focus on stillbirth or neonatal death. So a very narrow definition of fatality. This was in response to another study that had been published previously, where MRI exposure, gadolinium MRI exposure, was compared against non-MRI cases. So not use of non-gadolinium exposed MRIs. So I could compare patients who both need an MRI, and in one instance gadolinium is used and the other one is not. That was not possible in that previous study, but that's what we did in order to control the indication for the MRI, which of course could be a major cause for death, for fetal death as well. So the way we put that together, just to illustrate to you how we started out with this study and how many different data elements came in. So essentially what we need is we need conception, we need to capture the MRI exposure, we need to capture stillbirth, we need to capture live birth, and then we need to capture fetal sudden infant death in the first 30 days in the neonatal period. And we did this with a skeleton of Medicaid data. And actually, we used a reasonably older data sets when the concern about MRI exposure and gadolinium exposure during pregnancy hadn't really bubbled up yet, to avoid more confounding. And so the skeleton was claims data, so that we had the entire pregnancy history as well as mom's pre-pregnancy health history completely captured. What we did then is, What we did then is we linked the neonatal death data to the National Death Index so that we could get cause of death. Most causes of death in this early period are infections and trauma. This is not what we wanted. So we wanted to make sure that we capture sudden infant death that is not related to something that would not be, gadolinium related. We linked the live birth to Florida birth certificates and to the stillbirth to Florida fetal death records. This was a national data set altogether, but we have these linkages which allow us additional validation, which we did here with these two outcomes, as well as to bring in additional confounders like mom's educational status and things like that to ensure that we are not missing anything that might not be completely captured in the claims data. So they give us clinical estimates of conception. For those outcomes where we didn't have clinical estimates, we use our algorithm-based estimation of conception, which we have now down to about 96% of all pregnancies have an estimate that is correct within plus minus 2 weeks of conception. And then we used electronic health records from a national sample to validate stillbirth and to ensure that our stillbirth definition held true. And these were not miscarriages, but they were really pregnancy losses during later parts of gestation. So maternal characteristics, there's a lot of detail that went in here. This is a propensity score rating method that we used. I'm just showing this to you to give a little bit thought on the issues with confounding. One major part was, remember that we were comparing MRIs that used versus did not use gadolinium. We sat down with radiologists to understand when gadolinium might be used and what the advantage is. This led us to compare the different MRI sites that were focused in that MRI exposure. We removed pelvic MRIs, any MRI that might have to do anything with pregnancy. We wanted things that were not pregnancy related so that we really could control confounding. And that gives you already an idea, and that I think was the major part that I wanted to bring up here, is that we started out with an expert-informed propensity score, where we really went through, and that is a common approach that we use with any study that we're really doing. We're starting out with what could be potential reasons for confounders based on what we hear from clinicians' treatments decisions. And then we can supplement this with automated, like high-dimensional propensity scores to see whether we have whether we have missed anything in addition to that. All right. So in this particular case, we started out with more than 11 million pregnancies, and that's the other really important, learning with pregnancy studies. You need to use huge data sets because exposure of anything during pregnancy is fairly rare. And so it's extremely important to have the power to do what is needed in order to get here. So in this particular case, you see that we have in the prime analysis, we have 11 outcomes in the gadolinium exposed group, 73 in the gadolinium non-exposed group. You see that the adjusted risk ratios here all linger around 1. And then with the NICU outcome, which is more frequent, you see that they're right on 1. So the good news here was that there really doesn't seem to be an additional risk imposed by gadolinium use, which was really great news. But you can see the amount of work that it took to put that data set together to really be able to rule out that there is an increased risk. And you see that the confidence intervals are reasonably narrow, at least for the primary endpoint. Now, this study, with all the chart review validation we did and everything else that was that went into this, took more than 2 years to conduct. And so I wanted to finish with one piece that we're doing right now. This is Boost HP, a new study that we have funded right now, Big Data Approaches for Safe Therapeutics in Healthy Pregnancies. And so what we do here is, this is actually the largest data set that I'm aware of that has ever been assembled for pregnancy work. This is the NIH Collaboratory Distributed Research Network, basically an offspring of the Sentinel data set that FDA is using within Harvard. And then the Medicaid data that we are housing at the University of Florida with the vital data linkages that I just mentioned, to build a reusable, scalable approach and infrastructure to accelerate evidence generation on the safety and effectiveness of medications, using data mining methodologies, which are then formally evaluated in formal pharmacoepidemiological studies. So there's basically a data mining piece first, and then a formal evaluation piece and a formal causal inference study second. We do this with a software that's called TreeScan, which can evaluate relevant outcomes or exposures individually or in composite. So essentially, outcomes like malformations are clustered. They start on the individual level, but then, as you can see in this example here, they are clustered on various hierarchical levels that go up. And essentially, the data mining technology methodology then runs associations at any level of these clusters while accounting for multiplicity and multiple testing. And what that allows me is that I can look at individual outcomes if I'm worried that there's too much noise created when I'm clustering too large. But at the same time, I can also cluster meaningfully similar events together to have more power and to detect signals. So these are all the drugs that we're currently running through the TreeScan methodology, a lot of drugs for which we really don't have a whole lot of evidence. And then we're actually turning this around, and we are using an outcome and do a drug scan. So we have clustered drugs in a similar hierarchy, and we're looking at pregnancy losses and then the preceding types of medication exposures to see whether we can find more explanations, in particular for stillbirth. So one thing that I should say is the sophisticated design is infeasible in these high throughput scenarios. The control for confounding cannot consider specific risk factors for outcomes because we are scanning simultaneously for hundreds of outcomes at the same time, which of course has different risk factors and different confounding structure. So a high dimensional propensity score, which basically does an automated confounder collection, cannot really eliminate instruments in that scenario. And it does face challenges in achieving covariate balance. We have actually worked on this quite a bit now to deal with this. And it may not, and we are not able to consider active comparators necessarily because safety of similar drugs is sometimes not known. So an active comparator design may just not work. The target medication might be used in diverse clinical scenarios. So sometimes drugs are used for all kinds of different, the same drug is used for all kinds of different indications, and the comparators might just be too diverse. And the control must have high precision to avoid false positive signals. So we need large comparison groups in order to make tree scan work. So all of these are methodological challenges that we're currently working through in order to get all of this run, which basically means that, we basically have this tree scan part, but we also know that we will deal with false signals when we are running it. So we have a triage process where we have an expert panel that is looking at the biological plausibility of each of the signals that is generated, and then basically helps prioritize those signals that go into formal inferential designs. So this is my last slide. I'm running here, but I have to. So the thoughts here are real-world data must fit for purpose. We have heard that many times, but I hope I could illustrate this a little bit. To address confounding and measurement bias, multiple data sources might be needed. There are questions that cannot be answered with real-world data. I think that needs to be also very clear. And real-world data are rarely research-ready. The preparatory work, such as validation of study measures, is commonly needed. And I hope I illustrated this at this example here. The types of biases that are generated by the data must be known. And auto methods can be useful, but they must be, in my opinion, integrated in design. And I'll stop here and look forward to questions. This is my team and all the people who have helped us make this work successful. Thank you very much.